greatest pitfall I see when people leave the hospital to home or wherever they're going to go is they had a sudden intersection with healthcare. Whatever brought them to the hospital, they were sick, and it's hard to understand what happened and then what you're supposed to do when you don't even remember what brought you there.
There were a couple of incidents this year. I woke up in the middle of the night and I could not inflate my lungs. Could barely get any air. That had not happened before. We went into the ER. They admitted me right away. I spent a week that time. The second time was because of my potassium level and my kidneys were a problem. They did a follow-up blood test after the first hospitalization, and they called me and said, "Come right in." That's a little scary.
I think one of the main issues is that oftentimes physicians, when they're readying the patient for discharge, say the patient is medically ready for discharge, which is always true when they say that. But oftentimes they're going back into situations, either a social situation where there's lack of support, lack of finances, lack of resources, lack of sometimes even motivation on the patient's behalf to do all the things that they've been recommended to do to keep their health.
There should be a red flag. Big red, stop here, stop. But there is no visual cue for anybody to say stop, and you press the button and it lists all your concerns. How to be able to do that electronically would be of great value. We are doing better with actually having people talk to one another. So the clinical nurse leaders are now trying to call the care managers, which I think is great, so that at least we're having some kind of a warm handoff, like this patient's getting discharged, these are our concerns.
And when these handoffs are done well, the patient's needs are best served.
The discussions prior to leaving that afternoon was they explained in detail the meds I was to have taken. The doctor called, my pharmacy had everything set up for me and so forth. And the explanation was to do exactly what they told me, and I stood to that program 100%. It was very detailed. Again, me not being a physician, you don't know what's going on. You need really a good understanding. And they took the time. They took the time to tell me what to do when I got home.
There was an intern who discussed that with me, and that was shortly before discharge. He went through all the medications, renewed the prescriptions, and talked to me about the changes. So I was satisfied.
PT are recommending home with family. I think through Kaizen work that VMPS promotes, we have developed 4 processes currently at Virginia Mason that we use to help optimize care transitions. The first one, and one that I'm hugely involved in, is the transitional plan of care. So the transitional plan of care was developed to facilitate smoother transitions for the patient from the inpatient to the outpatient world. The second process that was developed as a result of Kaizen is the post-discharge follow-up phone call that the patient receives, which is a big support to the patient's discharge process. The third one is what's called the frequently hospitalized list, which basically it's a list that gets populated with the names of patients that are frequently admitted. And then from that list, there's a 4th process that occurs with the goal of optimizing care transitions, and that's the care huddle. A multidisciplinary team meets to discuss each of those patients and to try to put real actionable items that can occur based on the issues to try and support the patient when they leave and potentially reduce the risk of readmission.
What a lot of times why people come back to the hospital is that they have uncontrolled symptoms. So one of the things that palliative care does, and we've just started doing this, is we follow patients from the hospital to the clinic. And in particular, the heart failure clinic and really the oncology clinic is where we follow them. So what we try to do is make sure that their symptoms are managed, their pain, any other nausea, anything that is bothering them, make sure that that's managed so they don't return to the hospital for those reasons.
So you want to not readmit patients because you want them to leave 100%. But you know, there are certain situations that people, when they get home, things happen. And it's just nature again. This was a fluke of nature that was caused. It may never happen again in my future surgeries here at VM because I know I'll have them. And if that is the case, I know where to come.
The follow-up phone call or the post-discharge phone call is completely important because the nurse on the other end of the line can get a pretty clear picture over the phone based on just a few questions whether that patient is mentally functioning okay, that they can, restate what the plan of care is, can they articulate what brought them to the hospital and what they're looking for that might bring them back to the hospital.
The two main elements to help people transition from hospital to home are making sure that symptoms are managed and really good communication so that patients really understand what they can expect when they get home, what they should do if things go wrong.
I think sometimes we can get into the discharge mode of thinking, and the discharge mode of thinking is triggered by the physician saying the patient is medically ready. But more and more we're beginning to acknowledge that there's more to the discharge process than the patient just being medically ready for discharge.